Thank you very much for having me. I'm very much looking forward to talking to you about some of the advances in multi-cancer early detection today from GRAIL. My name's Joan Malcolm. I am going to just give you the standard disclosure, which is routine for us, and talk to you a little bit about GRAIL. It was formed in 2016, and it aimed to take on one of the world's largest challenges. I'm calling in today from Menlo Park in the heart of Silicon Valley, which is where GRAIL is based. And I get to work every day with leaders in the spaces of science, clinicians, engineers, and other experts, and provider institutions that really work closely with GRAIL. One of the great things about coming to work every day is that I'm surrounded by people who share a common mission, which is to detect cancer early when it can be cured. Many of us have been touched by cancers in our lives. My close friend, I grew up in Maine, a rural area, passed away 8 days after he was diagnosed with pancreatic cancer, which was incredibly alarming, but it really shifted my awareness of the gaps in early cancer detection, what it would really take to bend some of the cancer mortality curves. So I was very focused on putting my career into this work. Unfortunately, what happened with my friend is not unique. Cancer is one of the leading causes of death globally, with nearly 1,700 loved ones that pass away every day from cancer, and 3 times that many who get a first-time cancer diagnosis every day in the US. And Americans living in rural areas experience higher cancer mortality rates than urban areas, and also face pretty significant barriers to accessing quality healthcare. Despite improvements in treatments and prevention that have taken place in cancer and certainly contributed to the rate of decline in cancer deaths over the last few decades, rural areas have a slower decline in cancer mortality than urban areas, which is actually further widening the disparity. Geographic disparities are especially evident for lung, colorectal cancer, and cervical cancers. And one study found that there is an 8% higher all cancer mortality across all cancers, and almost a 20% higher lung cancer mortality in rural communities compared to urban. There are a number of factors at play here, including older average age of rural populations, lack of access to quality care, delayed diagnosis, and higher likelihood to engage in cancer-causing behaviors, such as smoking cigarettes or physical activity. But for all of those, we see early detection as one potential opportunity or tool in the toolkit to help shrink this cancer care disparity that we're seeing. So there's a staggering toll that cancer takes, certainly in the years lost of lives in life. And if you add that all up, it's 8.7 million years of lost life in cancer. And there's a direct cost of over $200 billion a year to the US, and a total economic burden of over $1.3 trillion. The toll is incredible, and treatments and advances are certainly contributing to reducing overall mortality, but finding cancer early is one of the best ways to reduce the costs associated with that cancer treatment. So early diagnosis is GRAIL's focus because survival rates are better when cancer is detected earlier. The 5-year cancer-specific survival when diagnosed earlier before cancer has spread is 89% compared to 21% when it's diagnosed late. While there are over 100 cancer types, available screening only exists for 5 cancer types. So unfortunately, most cancers are detected at later stage. Research has also found that rates of late stage diagnosis are higher among individuals living in rural areas. For example, one study found that the odds of a late stage breast cancer diagnosis is 11% higher among women living in rural communities compared to their urban counterparts. And another found a relationship between rural residents and stage 4 colorectal cancer. Even among cancers without screening, patients living in rural areas have significantly lower rates of early stage pancreatic cancer compared to those living in non-rural areas, indicating that rural residences might be a predictor of late stage diagnosis. Unscreened cancers, as I mentioned, there's only 5 of them, and they're generally detected at later stages. You can see this in the number of cancers by types that are detected after a metastasis has already occurred. You can see that for those in the blue, there are current guideline recommended screenings available, and they are lower. But the vast majority of cancers, which has a very long tail in different types, tend to have later stage diagnoses. What's also remarkable is that 71% of the cancer deaths that occur from cancer are from cancer types that have no existing screening today. The vast majority of cancer deaths come from those that aren't even being looked for. That's the single greatest need, finding a solution for detecting many more cancers early that GRAIL sees and what we come to work every day to focus on. So, as I mentioned earlier, rural communities face unique challenges, and the disparity rates between cancer mortality among urban and rural communities is growing. There are vast barriers to that, but one potential tool to help drive this is easier access to early detection technologies. What GRAIL sees and provides is a blood test that would allow for a first indication to pick up a signal of cancer that can be done at any blood collection site. COVID has also opened up some really interesting perspectives and really showcased some of the vulnerabilities in the cancer screening systems that we have today. There's a significant decline in cancer screening of those recommended cancer screening tests that are available today. In some cases, they're down over 60% in adherence to screening. The National Cancer Institute recently came out with a statistic that in breast and colorectal cancer alone, this delayed screening due to COVID is likely to result in an additional 10,000 deaths. That's from breast and colon cancer alone. That really is showcasing that there is an opportunity here to build a much more resilient cancer healthcare system. And something like the GRAIL technology is one available option for that. So we're at this point in understanding of genomics and biology and cancer where we're really seeing new insights by understanding signals that are present in what's called circulating cell-free DNA. So if you can pick up and collect this cell-free DNA that circulates throughout your blood, deeply sequence it with technologies that have really recently become available, and then provide machine algorithms and learning to pick up patterns that recognize a cancer signal from a non-cancer signal, the possibilities are truly remarkable, and it opens up opportunities for a real paradigm shift. So every tumor, generally as it divides, will release some subset of cells. Those cells break down, there's fragments of DNA circulating in the blood, and that's what GRAIL collects through the plasma. Once it isolates these cell-free DNA signals, it can interrogate it and compare it to non-cancer signals to investigate whether there's any pattern that it can pick up. GRAIL's figured out this pattern and built these algorithms based on a population scale clinical development program. We've had robust studies, over 4 of them, and over 145,000 participants enrolled, that have given us the ability to really refine and pick up this pattern of cancer in the blood. What that's resulted in through all of this, these studies, this algorithm development and validation of our test is a true assay that can pick up over 50 different cancers, many of which are unscreened for today. It also is meant to be a population health test, a screening test, so a very low false positive rate, so as not to create an overburden or confusion within the system is key. And we found and validated that our assay has a less than 1% false positive rate. We also have a 67% sensitivity for stages 1 through 3 alone of cancers that represent 2/3 of the cancer deaths in the US. In addition to being able to detect whether a cancer signal is present or not present, we're also able to predict the location of where that signal is coming from in the body. And we can do that with greater than 90% accuracy. It's been validated in our recent study as 93% accurate in that location prediction of this technology. And it's really designed to integrate into clinical practice, into any clinical practice. So primary care is the mechanism with which this test would be prescribed by an ordering physician. The sample is collected in any lab that can collect blood by a phlebotomist, and the results are provided back by the primary care. The vast majority of tests will be cancer signal not detected, and it creates a great opportunity for physicians to have conversations about the importance of screening with patients. If there's a cancer signal detected, however, it triggers the need for a diagnostic workup and an evaluation for cancer, and understanding from that patient that they need to get worked up and directed for care. So GRAIL's test was designed to detect all cancers, as many as possible, and currently we detect over 50. We aim to complement existing single cancer guideline recommended screenings today, not replace them. We are optimizing our test for the highest cancer detection rate across participants. So we are not optimizing it to have a higher sensitivity for any one given cancer. We want to detect as many cancers of any type as early as possible. And as I mentioned earlier, we were really focused on minimizing harms because this is a early detection or population health test. We need those low false positive rates. So that's really been how the algorithm and entire assay has been optimized. So I mentioned early that the multi-cancer early detection test is a complement to existing screening paradigms. That's remarkably important, and we want to implore anybody who's due for one of those guideline recommended screening tests to keep up to date with them and talk to your doctor. But what's interesting is that often when you go for those tests, you're much more likely to have another cancer that single cancer screening test isn't going to pick up. For example, if you're somebody who's 50 or now 45 or older going for a colorectal examination, you have your colonoscopy, you have a 10 times greater likelihood of having a different cancer than the colon cancer you're being worked up for. So while that test is critically important, it's not enough. We really need to approach this from a multi-cancer approach. So if something like the Gallery, which is the name of GRAIL's test, blood test, was added to existing guideline recommended screenings today, so you continue with those screenings, but you add in this blood test to flag for additional cancer types, it's modeled that this would allow us to detect 3 times more cancers than we currently do today, with significantly less false positives added to that system. What this aims to do on the left is really push and revert the number of late stage cancers that we currently experience. So in gray, there are many stage 4 cancers that are diagnosed today, but our aim would be to pull as many forward into earlier stages as possible. And doing so, as we talked about earlier, results in a better probability of survival over 5 years. And it also is modeled to avert over 100,000 deaths annually. So looking ahead, GRAIL is focused on a pretty significant paradigm shift that requires many partners on all ends, our health system partners, our policy partners, our education partners, to really embed something like multi-cancer early detection into our healthcare and turn it from a promise into saved lives. So awareness is one, making sure the public and diverse stakeholders really understand this unmet need and understand things like 71% of our cancer deaths come from cancers that have no screening today. We're also incredibly focused on our evidence generation programs. As I mentioned, we've enrolled over 145,000 participants in clinical trials, but we also really need to understand how this test influences clinical care practice when it's really used in true clinical care settings. So providing access to this test and evidence generating frameworks and partnerships with scientific communities and regulators is incredibly important to us. we're also looking and have engaged in really meaningful partnerships with leading providers, both community-based hospitals and large academic health systems, to really ensure that the guidelines that are necessary for those clinical minds to develop come quickly into the field. And then last, we are focused on providing equitable access to this kind of technology. And that is a priority to support consensus policy solutions to allow this access to occur. So with that, I hope I provided a quick overview, and I'm happy to, and I look forward to taking any questions.
Okay. What are some challenges for patients today in accessing new and innovative cancer therapies?
Great question. So we talked about some of the particularly rural health challenges and access to centers that are screening. You know, on average, rural residents are 11 miles away from their local hospital, urbans are 4. So there's location and geography. But I would also say that particularly in new technologies in the screening realm, there isn't as direct access to reimbursement, even Medicare reimbursement. That can generally take up to 10 years and requires legislative policy changes to allow for those preventative services to be covered by Medicare. So through that, a number of policy partners, many of which are your Texas representatives, have actually supported a bill that would allow for technologies like this, like GRAIL's test, but many others that are focused on multi-cancer early detection, to have reimbursement as soon as they are FDA approved and not have to wait the standard 10 years that Medicare coverage typically requires for preventative services.
Can you tell us more about the clinical trials in Texas?
Definitely. So at the moment, GRAIL has partnered with Texas Oncology, the Sarah Cannon Research Institute, and Texas Oncology West as part of their pretty ambitious clinical study program, which we see as the largest in genomic medicine, certainly within methylation, which is the kind of technology that GRAIL uses. It has had over 145,000 participants, but many partnered right within Texas that have enrolled. Our recently completed study was the Pathfinder study. That study looked at, we validated and had a confirmed test where we understood the performance and how well it was able to detect cancer in the blood and predict its location. But what Pathfinder did was to say, then you put that kind of test in clinical practice, and what happens? How does a physician use it? How do different healthcares decide to triage or manage the workup of patients who have a positive result? How are they directed for care? And that was the most recently completed study, and the data from that will be released at ASCO, which we're all very much looking forward to sharing.
What is being done to address the coverage challenges that MCED faces?
It's a great question, and we're really deeply engaged with employers, private insurance payers, and others with the goal of providing coverage for the test once it is available. I think I got muted there. So I'll start from the beginning of that response. We're really deeply engaged with employers and private insurance programs. Sorry, there's a Zoom clicking on here. With the goal of giving coverage to the test as quickly as possible once it becomes available. But when it comes to government programs such as Medicare and Medicaid, coverage rules, as I mentioned, provide pretty limited coverage for cancer screenings and other preventative services. So the cancer advocacy community and policymakers are working together to really address those rules, which GRAIL is fully supportive of. One policy proposal that was recently introduced is Similar to steps Congress took to allow Medicare coverage for colonoscopies and mammographies, it's a real legislative act. The cancer advocacy community, which was led by Prevent Cancer Foundation, recently sent a letter with over 300 organizations across all 50 states to Congress that was voicing support of this bill that would allow for this coverage of any FDA-approved early detection technologies. And the full text can be found on the Prevent Cancer Foundation website if anybody is interested. But the bottom line is that in order to get this test to be accessible to everywhere, and this paradigm shift to be really have the ability to be utilized by those who need and want it, we need to have this kind of policy shifts that are occurring. So I will also say that there is a bipartisan group of even Texas legislators, including Representative Jody Arrington, Sheila Jackson Lee, Dan Crenshaw, and Eddie Johnson, who have supported this bill that I was just referencing in the House of Representatives that would allow Medicare to provide this coverage.
We really appreciate your time and zooming in all the way from California. So the audience, again, appreciates it. So let's give her a round of applause.
Thank you all for having me.